Good morning all. My topic for today is fundamentals of tooth preparation. Coming to the father of dentistry, G.V. Black, he is the first person to classify the cavity preparations. When you talk about need for the restorations, why do we have to restore the tooth? The first thing is caries. Dental caries is the main objective why we are going to remove the decay and restore the tooth. Next are the non-carious lesions. Apart from the caries, there are various non-carious lesions like adhesion, abrasion, erosion and abfraction, all of which require restoration. Next one is a replacement of restorations or repair, and also as a preventive dentistry. Before even going for caries or any damage to the tooth, as a preventive dentistry we can go for pit and fissure sealants or any enamelloplasty preparations to prevent the further decay. Coming to the main thing, the definition of cavity preparation. It is defined as a mechanical alteration of diseased, defective or injured tooth in order to best receive a restorative material which will in turn replace the tooth and the area to a proper form, function and aesthetics. The objectives of cavity preparation are to remove all the defects and to give necessary protection to the pulp and to locate the margins of the restorations as conservatively as possible, and to form the cavity so that under the masticatory forces the tooth and the restoration will not fracture and the restoration is not displaced, to allow for the aesthetic and functional placement of a restorative material. Coming to the tooth restorations, there are two types, the intracoronal restorations and the extracoronal restorations. The intracoronal tooth restorations are something where we make a cavity preparation and go for a restoration. The extracoronal tooth restorations include covering of the full coverage restorations. Coming to the tooth preparation, there are various types of tooth preparations like conventional and modified preparations. When you talk about an intracoronal restoration in detail, these are the parts of an intracoronal cavity preparation. A cavity preparation like a class 2 involves a mesial wall, a lingual wall, a pulpal wall, buccal wall, proximo-buccal wall, proximo-lingual wall, axial wall and the gingival seat. Coming to the extracoronal cavity preparation, it is a stump-like having walls or surfaces that result from removal of most or all of the enamel. It's termed as a crown or a cap enveloping the remaining tooth crown and thereby restores some of its lost strength. Coming to the classification of the cavities, there are many classifications, but we are discussing about two of them right now. One is G.V. Black and the other one is Graham Mount. The most commonly used is the modified G.V. Black classification, which tells us about class 1 to class 6. When we go into we'll go into the detail later, but now about Graham J. Mount classification, he has given the classification in terms of a table. This table gives us the classification based on the size of the cavity and site of the cavity. In the size, it is classified as no cavity 0, minimal 1, moderate 2, enlarged 3 and extensive 4. And in the site, it is classified as 1 pit and fissure cavity, 2 the cavity in the contact area and 3 in the cervical area. Based on the size and the site, it is classified as 1.0, 2.2, 3.3, etc. Coming to the G.V. Black's main classification, it is classified as class 1 to class 6. Coming to the class 1 involves caries in the occlusal surfaces of the posterior teeth or occlusal two-thirds of the facial or the lingual surfaces of the posterior teeth and also lingual surface of the maxillary anteriors. Coming to the class 2 involves the proximal surfaces of the posterior teeth. Class 3 involves the proximal surface of the anterior teeth. Class 4 involves the proximal surface of the anterior teeth along with the involvement of incisal. Class 5 is nothing but the cervical caries on all the teeth, either it is facial or lingual. Class 6 involves caries on the cuspal tips or the incisal edges. So what are the factors do we have to consider in cavity preparation for a successful restoration? The type of the dental restorative material, physical and biological properties, and the tooth, its location and also the masticatory forces. Anatomic tooth crown versus clinical tooth crown. What is the difference between anatomic tooth crown and clinical tooth crown? Clinical tooth crown is something which is visible in the oral cavity. Anatomical tooth crown is when you extract the teeth, the CEJ to the incisal edge comes under the crown according to the anatomic tooth crown. Tooth preparation terminology. First classification is simple, compound and complex tooth preparation. A simple tooth preparation is something which is involving only one surface. A compound tooth preparation is involving two surfaces, and a complex tooth preparation involves two or more surfaces, more than two surfaces. Coming to the nomenclature, as we already discussed, all the walls in the cavity preparation are already named, and you always use dental languages for communication, not like a layman. So we use the language like walls, cavities, line angles, cavo surface margins, bevels, point angles, and each wall is communicated in the same way with everyone using the dental language. Coming to the components of the cavity preparation, the same thing in detail. If you come to the cavity walls are called external walls or internal walls. For example, the external walls are enamel wall, dentinal wall, mesial wall, facial wall. But coming to the internal wall, the axial wall, pulpal wall, all these are the internal walls. Coming to the cavity preparation angles, they are classified as line angles, point angles, and also a cavo surface angle. The cavo surface angle is the angle between the internal wall and also the external wall. The line angles are also again classified into internal and external line angles. Coming to the miscellaneous components, they are retentive grooves, dovetails, bevels, including long, short or full bevels. So these are the external walls which are shown in the picture, and also the internal walls, the pointing out as pulpal and the axial walls. The line angle, coming to the definition, it is a junction of two planar surfaces. They can be internal or external, and point angle is a junction of three planar surfaces. Here we can see the line angle and point angle numbers in each cavity preparation, like class 1 to MOD cavity preparation. In class 1 we have 8 line angles and 4 point angles. In class 2 11 and 6, class 3 6 and 3, class 4 11 and 6, class 5 8 and 4, and in MOD it is 14 line angles and 8 point angles. So coming to the definition of the cavo surface margin, it is the angle of the tooth structure formed by the junction of the prepared cavity wall to the external tooth surface. And coming to the definition of a bevel, it is an inclination that one surface makes with another when not at the right angle, or in cavity preparation a cut that procedure an angle other than 90 degrees which is given on the cavity wall. Similarly, retentive grooves, dovetails and isthmus. Dovetail is very important for retention. It is a widened or fanned out portion of a prepared cavity which is established to increase the resistance and also the retention form. Isthmus is a junction between the occlusal and the proximal parts of the cavity. Coming to the stages in cavity preparation, they are divided into initial stages and final stages. The initial stages are outline form and initial depth, primary resistance form, primary retention form, and convenience form. Coming to the final tooth preparation stages, they are removal of any infected dentin, old restorative material, pulp protection, secondary resistance and retention form, finishing of the external walls, and final procedures like cleaning, inspecting, and sealing. The first step is initial cavity preparation. It is defined as the extension and initial design of the external walls of the preparation at a specified limited depth so as to provide access to the cavity or defect to reach sound tooth structure, resist the tooth from fracture or restorative material from masticatory forces principally directed along the long axis of the tooth, and retain the restorative material in the tooth. In which the first one is outline form and initial depth. The outline form means placing the cavity margins in the position they will occupy in the final preparation, except for finishing of the enamel walls and margin, which is done in the final steps. The principles include all the friable weakened enamel should be removed, all faults should be included, and also enameloplasty is included in the outline form. All margins should be placed on sound enamel, preserving the cuspal and marginal ridge strength and minimizing the facial-lingual extensions as much as possible. We have to connect any two cavity preparations if the distance between two of them is less than 0.5 mm. Restrict the depth of the preparation into the dentin in 0.2 mm for pit and fissure caries, and for smooth surface is 0.2 to 0.8 mm. Extend to provide sufficient access for cavity preparation, restoration, placement and finishing. See, these are some of the designs in the outline form. We can see a mix of designs like class 1 with class 2, or class 2 with buccal extension class 1, or separate class 1 and class 2. Such designs exist. Coming to the enameloplasty, any deep pit or fissure which can lead to future caries or lodgement of the food. It can be smoothened into a saucer-shaped cavity so that it becomes self-cleansing. Coming to the primary resistance form, it is a shape and placement of preparation walls that best enables the tooth and the restoration to withstand without fracture the masticatory forces delivered principally along the long axis of the tooth. Coming to the principles of the resistance form, the adequate depth of the bulk of the restoration, flat floors, box shape, rounded internal line angles, preserving the cusps and the marginal ridges, inclusion of weakened tooth structure, reduction of the cusp for cusp capping, and definite KO surface margin. The flat floors is something like this. If you can see, the floor of the cavity is parallel to the pulpal roof. It is not flat, not parallel to the cuspal plane. The KO surface margin 90 degree. If you can see the cavity angle between the prepared tooth wall and the external tooth surface, it should be 90 degrees maintained. As you can see here, box shaped cavity and flat floors help in good resistance form. Here we can see the parallel walls in the first diagram and the box shaped cavity in the second. Here we can see the definitive line angles and point angles. It should always have rounded line angles and point angles but definite ones, and also it should accommodate bulk of the material for it to retain inside the cavity. These are the prepared cavity walls. Coming to the cusp capping, even cusp capping when required also enables us to increase the resistance form of the cavity. Coming to the third point, the retention form. It is the shape or form of the prepared cavity that resists the displacement or dislodgement of the restoration from the tipping or lifting forces. The occlusal convergence and the dovetail are two important things useful for retaining the restoration. The box forms, the convergence, the dovetail, and also if you are using resin composites, then always acid etching helps us in the retention form. For composites, it increases the mechanical bond and also the beveled enamel margins. For cast metals, it is parallel or vertical walls with a divergence of 2 to 5 degrees per wall. And for gold, it is the condensation pressure, the frictional retention, elastic deformation, inverted truncate cone shape, and also the dovetails. So these are the dovetails, which are the fan-shaped portions of the cavity preparation. This is showing the occlusal convergence of the box of a class 2 cavity preparation, increasing the retention form. Coming to the fourth point, the convenience form. It is that shape and form of the cavity that provides for adequate observation, accessibility, and ease of operation in the preparation and also the restoring the cavity. This convenience form can also be checked using the PFI, the plastic filling instrument. The condenser point needs to be inserted into the cavity and checked for the convenience form of the cavity. Coming to the principles of the convenience form, the extension of the mesial, facial, distal, lingual walls should be adequate to provide for access into the deeper portions of the cavity, and also the occlusal divergence is required for the cast metal restorations. The fifth one, which comes under the first point of the final preparation stages, is the removal of any remaining enamel, pit and fissure, and infected dentin or old restorative material which is remaining after the initial cavity preparation is done. So it involves the elimination of any infected caries of the tooth in the tooth structure or faulty restorative materials left in the tooth, and removal of infected dentin and also preservation of the affected dentin, as we have to decrease the risk of exposure of the pulp. The old restorative materials also can be removed if there is any secondary caries found beneath the restoration, periphery of the restoration is not intact, or the tooth is symptomatic. And for also aesthetic purposes, like few patients would ask for a composite restorations rather than an amalgam old restoration. Caries and infected dentin is removed using spoon excavators by flaking up and peeling it off in layers, or you can use a slow speed round burr to remove the caries under air water coolant. The old restorative material with round carbide burr with air water coolant at a slow speed like a micromotor handpiece. This comes is the infected and affected dentin differences. The infected dentin is always identified as soft, leathery, and flaky and deeply discolored, whereas the affected dentin is hard and very slightly discolored. In infected dentin, the collagen is irreversibly denatured, and the collagen is reversibly denatured and it can be mineralized in affected dentin. There are microorganisms found in infected dentin, but there are no microorganisms in the affected dentin. During the cavity preparation, we also have to remember that infected dentin needs to be removed, but affected dentin need not be removed. The sixth point is the pulp protection. Pulp protection is a primary objective of protecting the pulp, which is already our main objective in the cavity preparation. So application of varnishes, liners and bases is very important in protecting the pulp. The identification or selection of various pulp protecting agents is based on the remaining dentin thickness. So when the thickness of the remaining dentin is less than 2 mm, the heat generated by injudicious cutting may cause pulp burn lesion, the abscess formation and also the depth of the pulp. So the pulpal irritants and the stimuli which causes all these are some ingredients in the restorative materials like chemical, for example phosphoric acid in the zinc phosphate cement, thermal changes conducted through the restorative materials, the heat changes, the forces which are applied, and also the galvanic shock due to different metals used in the oral cavity, micro leakage, etc. Coming to the secondary resistance and retention forms, here we have included many other features to increase the retention and resistance form to the next level. For example, the mechanical features include the retentive locks, grooves, coves, skirts, the groove extensions, beveled enamel margins, pins, slots and also amalgam pins. All these things are the secondary retention features, the mechanical features which can be incorporated to increase the resistance form. And also coming to the composites, the etching, priming and bonding also helps in increasing the retention form. The vertically oriented retention locks and retention grooves are used to provide additional retention in the proximal portions of the cavity preparation. The locks are used for amalgam and the grooves are used for cast metal restorations. When you talk about the locks and grooves, there is a primary difference between the locks and the grooves. The locks are given in the line angles of the proximal cavity of the cavity preparation for amalgams, where the base of the triangle is faced towards the occlusal surface, whereas for cast restorations, the base of the triangle is given towards the gingival seat. If you can see in the diagram, that is the area where the locks or the grooves are given. For cast metal, if the base is facing towards the pulpal floor, it is easier for a cast metal to insert into the cavity preparation. Whereas for amalgam, it is locked because the base is facing the gingival seat. Coming to the slots and pins, these are the pictures representing the slots or pins and the place where it can be inserted for additional retention. Coming to the proceedings for finishing of external walls of the cavity preparation, it is a further development when indicated of a specific cavo surface design and degree of smoothness that produces maximum effectiveness of the restorative material being used. The objectives is to create a good marginal seal, that means a smooth finish between the restorative material and the external tooth surface, and smooth marginal junction, and also increases the strength of the tooth and the restoration at the margins. Coming to the ninth one, the final procedures of cleaning, inspecting and sealing. The definition includes cleaning or debridement is the act of freeing the preparation walls and margins from the objects that may interfere with the proper adaptability and behavior of the restorative material. The objectives are of freeing all the preparation walls, floors and margins from enamel and dentin chips resulting from excavations and grinding, and also any other extra restorative material which is remaining at the margins. Drying the preparation walls, floors, margins from any moisture coming from saliva, blood or any other exudates, and sterilization of these walls using an astringent. Air water spray can be used to remove all the debris remaining in the cavity. Alcohol can be used to remove the moisture, and varnishing can be used to seal the dentinal tubules further. Conditioning can be used to remove the smear layer. Thank you.